Right.
is joining us.
Thank you. And Dr. Gaur, Dr. B. Kalpana ma'am, who has talked latest?
Ma'am, I have talked. She will join, ma'am.
Right. She'll be in the airport, I think.
I'll
We are
call.
going live in 3, 2, 1. We are live now, ma'am.
Good evening, everybody. Myself, Dr. Vishal Dave, Medical Advisor at Intras Pharmaceuticals. On behalf of Intras Pharmaceuticals, I welcome you all for this first webinar of MS The Synergy Club on the topic Pulse of Fetal Medicine. Before starting the webinar, we would have a lamp lighting ceremony.
शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः शत्रुबुद्धिविनाशाय दीपज्योतिर्नमोऽस्तु ते दीपज्योतिर्नमोऽस्तु ते शुभं कुरुत्वं कल्याणम् आरोग्यं धनसम्पदः.
I would like to introduce Dr. Monica Singh. Dr. Monica Singh is Consultant Reproductive Medicine, Bhopal Fertility and Endoscopy Center. She is Professor LL Medical College, Bhopal. She is Managing Committee Member, ESAR. She is Vice President, Bhopal Obstetric Gynec Society. Now over to Dr. Monica Singh, madam.
Thank you so much, Dr. Vishal. And it's a great pleasure to start the Synergy Club. And this is a purely academic club. And we have the same old team with a new presentation. And we have dignitaries from all over India. Dr. Bela Bhatt is a very, very great mentor and friend and well-wisher. So we started with fetal medicine, a subject which is very close to my heart. And it is a great pleasure that we are collaborating with MPOX. And I have the great fortune of being the co-chair of the Perinatology Committee of MPOX, which is the All MP OBGY Societies organization, headed by President Dr. Professor Kavita N. Singh, who is also our chief guest for the evening, and a very dynamic secretary of MPOX, Dr. Dipti Gupta, who is, with us since last couple of seasons of our webinars also. So I would like to first speak 2 words about MPOX, because just now I got a message from Bela ma'am. Monica, what is MPOX? So like MOX, we have got MPOX ma'am, and it may not be as huge as MOX, but still we are very proud of it, because it is an association which was made with a lot of love. And this is actually a research and public welfare organization. The founder president was from Bhopal, late Professor Dr. Bimal Gulati, nearly 35 years back, with lot of input from from Professor Madhuri Chandra from Bhopal. And it was formally registered with the Registrar of Societies in 2015. At present, we have got 12 societies making up MPOX, with nearly 1,800 registered OBGY members all over the state. So we are having, giant mentors and teachers, and we strive to take the organization to greater heights with our academic, cultural, and social, as well as medical efforts reaching to every patient that we see. The entire team has been formed, ensuring representation and participation of all member bodies, as well as teaching institutes. The teaching institutes have been selected from all over the state, and every faculty teaching in these teaching institutes is a very, very respected member of AMPOX. The vision over the years is that AMPOC wishes to conduct various offline and online activities in order to strengthen the organization and pursue academic excellence. We also wish to increase awareness activities, reach out to masses, and especially benefit healthcare workers. We are positive that with perseverance, persistence, and dedications to women's health, we'll be able to reach utopian heights in maternal health and reach the magic figure of maternal mortality of less than 2 digits soon in Madhya Pradesh. Thank you so much. And now I would like to welcome warmly President MPOX, who is also Dean of Gandhi Medical College, Bhopal. Madam has recently taken over. She has moved from Jabalpur to Bhopal to head the largest medical college in the state, that is GMC Bhopal, also my alma mater. She is professor and HOD at NSCB Medical College, Jabalpur. She started with that post, then moved to Bhopal. Madam is a very keen academician with a great interest in gynec oncology. So she is ISCA Fellow Gynecology Oncology at Roswell Park Cancer Institute, trained at New York, and also Tata Memorial Hospital, Mumbai, and the Regional Cancer Center, Trivandrum. She is a WHO SEARO trainer in colposcopy with over 20 years of teaching undergraduates and postgraduates. President of AMPOX 24 to 26, President MPSC AGOI 23 to 25, has been the president of Jabalpur OBGY Society 2013, president of MPMTA NSCB MCH 2015-16, as well as headed Rotary Club of Jabalpur, been secretary, organizing secretary of many AMPOX conferences, and the very successful organizing chairperson of AOGIN India Conference 2013. Madam is there in many medical education committees, ethical committees, MP MSU, master trainer of so many cervical cancer prevention programs, master trainer
I'm
in.
unable to hear you. Can you see me or can you hear
Yes,
me?
ma'am. Yes, ma'am.
Monica,
Yeah. Yes, ma'am. We can see you and hear you, ma'am.
I'm unable to hear you.
Oh, so ma'am, can you please,
Can help me?
ma'am, can you, I think you
I can
can try.
see you, but I
Maybe-
am unable to hear you.
Madam, are you from phone or laptop? Joined on phone or laptop? Dr. Dipti, Dr. Neetu, can you call madam once?
Yes, ma'am. Yes, ma'am. Calling.
Please help out, madam. Madam, can you hear me now? Kavita ma'am? No, madam is not able to hear.
मेरी आवाज आपको आ रही है क्या?
Yes,
मुझे आपकी
yes,
आवाज
ma'am.
नहीं आ रही,
I'll send.
पर मुझे मोनिका की आवाज नहीं आ रही. दूसरे सिस्टम पे लॉगिन करके देखती हूँ. तब तक आप प्लीज कैरी ऑन.
Okay, ma'am. Yes, ma'am.
Monica, please carry on because I'm trying to log in on another system.
Ma'am, you
I can see you, but I cannot hear you. So
Oh,
I'm trying on other system. Meantime, you please go ahead.
yes, ma'am. Taking forward Madam's brilliant CV, Madam has been the recipient of various national, academic, and service awards. She has been the recipient of Foxy Durusha Community Service Award in 2023, Dr. Usha Swaraya Foxy ICOG Guest Lecture Award in 2012, Best Community Service Rotary Award from 6 to 13, Best Scientific Video Award at CIFOC Conference, Agra, recipient of Dr. Kamini Rao and Dr. P.C. Daruwala Oration Award in 2007-8, and published 39 articles, author of 10 undergraduate and postgraduate textbook chapters, and faculty and live workshop in 3 live workshops, and guest speaker in 75. We are waiting for Kavita ma'am to join.
Yeah.
Yes.
I'm able to.
Yes, ma'am.
Now I can hear you.
Very
Yes.
good evening, Kavita.
Sorry. Yeah, very good evening. I'm sorry for little technical hitch on my side. At the outset, I would like to congratulate you as well as the entire team and all the learned faculty, participants, everyone on behalf of MPOX. And I'm in my office, so I'll be just listening to all the deliberations which are going to be there. So my best wishes to all of you. I think I should not waste much of your time, precious time, because everyone wants to listen to our experts, Dr. Prashant, Dr. Bela, and Dr. Kulbhushan. So I'm going to learn.
Thank you. Thank you so much, Kavita ma'am. And it is so heartwarming for us that you have joined from Dean office, despite I know you have such a hectic schedule. I can, understand every minute of your day is planned. So
But dear, the best time is the academic time,
yes.
Administrative responsibilities are totally different, but something which I love and really I don't want to miss is the academics. Early in the morning, I went to theater. I operated one onco C endometrium. Then I helped and I was there with Shabana for an diagnostic laparoscopy, and then I came to office. So it was like that. All the best to you, and my best wishes are there with everyone in the team.
Thank you.
So thank you so much. Thank you.
And madam, we also introduce MPOX for all our guests who have
Yeah.
joined. We
Yeah,
spoke
yeah.
MPOX when it was formed, how it was formed, how many members, and what is the vision.
Great.
Thank you
Great.
so much, ma'am. You are the reason behind MPs. You are the driving force behind MP. And
I am a driving force because I have people like you. Thank you
Thank-
so much.
thank you so much, ma'am. So this is the slide we have made for MPOX, ma'am.
Yeah.
And this has been beautifully designed by Dr. Purva. She has mentioned about the foundation, number of members, the vision, and how we are, making MPOX work, reach further and further heights.
And Monica, we are looking forward for one more big event in Bhopal at GMC, which I'll just share after this academic event, right?
Sure,
Okay.
ma'am.
Thank
Sure.
you. Thank you.
Sure,
Thank you so much.
Thank you so much for joining, ma'am. And now I would like to introduce the Secretary of MPOX, who has been also the right hand of Dr. Kavita, ma'am. And she is the reason why we see so many activities from MPOX at regular intervals, not only academics, but also like she interacts very well with all the members. She has a wonderful relationship with all seniors and juniors. She is heading the quiz committee beautifully. She encourages the cultural activities, the essay writing, and all the the out of the box topics are mentored and promoted by her. She's working as associate professor in NSCB Medical College, Jabalpur, and she's also heading the Ankur Fertility Clinic in Jabalpur. She is at present the secretary of AMPOX 24 to 26, immediate past secretary of Jabalpur Obsgynae Society 23 to 24, the West Zone coordinator of Foxy Quiz Committee, the national corresponding editor of Jogi, as well as peer reviewer of Jogi, the co-editor of Foxy Focus on RPL, and also a very active member of MP ISAR and MP AGOI. We welcome you, Dr. Dipti, and kindly
so much,
we would
ma'am.
like to have a few words from you.
नहीं मैम मैं बहुत छोटी हूँ and we are extremely grateful for that you have taken this initiative on behalf of Perinatology Committee member MPOX and I have actually been very lucky कि मुझे इतने अच्छे seniors mentors and मतलब कविता सिंह मैडम I always keep telling her कि मतलब it is nothing but sheer destiny कुछ लोगों का सानिध्य अब हमको प्राप्त होना होता है and that is how all of us learn and grow and we are sincerely trying and hoping that we will be able to bring all our MP members together on one page and infuse a new spirit of enthusiasm academics under Madam's leadership and guidance and inputs from all of our senior members and patrons. And best wishes to you, ma'am, for this series. And like Madam said, I am sure you always bring out so many good topics and speakers. So really looking forward to the entire, not just this webinar, but the entire series. Best wishes, ma'am, and thank you for the opportunity.
Thank you. Thank you, Dipti. Those were really great and very sweet words. And now, without wasting time, we have several more guests to welcome and bless us. We have our special guest, Dr. Yashodhara Gaur ma'am, who has joined us from Gwalior. Can I have Dr. Gaur, Madam CV? Dr. Yashodhara Gaur is professor and head of the department of Gajra Raja Medical College, Gwalior. She is a medical teacher since the last 25 years, president of the MP State Chapter of Association of Gynecologic Oncologists of India in the year 2023, and Gwalior is hosting a very prestigious state oncology conference in the coming few days. In fact, 13th, 14th, 15th of September, this month only, which is going to be attended from oncologists, gynecologists, as well as gynecologists all over India. We wish the conference a very big success, madam. Madam is also the West Zone Coordinator of Foxy Oncology Committee 21 onwards, the Vice President of AMPOX 20 to 22, the President of Gwalior Obsgynae Society, a very, very vibrant society. Hello, sir, we are live now. I'm very sorry. I got a call from Dr. Prashant Acharya. Could Neetu, please, could you call sir? He is having some problem with registration,
Yes,
please.
ma'am. Yes,
Yeah.
ma'am.
Madam has been the past president of Gwalior Opskynie Society, which is a very vibrant and active society of MP and has had many national and international publications. We are honored to have you, Dr. Gaur, amongst us. Personally, I have got a great regard and I thank Yashodhara Gaur ma'am with all my heart. Because of her, I was, totally happy when my daughter was in Gwalior for 6 years under her care. She was her mentor and she was a very big, support for her. Thank you so much, ma'am, and thank you for joining the program. We would like to have few words of blessings from you, madam.
Thank you, Monica, first of all, for making me a part of this, your new venture, Synergy. And I must appreciate your hard work and your dedication towards sharing your knowledge with all of us, with our new generation, and showing them a path to what to do next. And of course, you are having very vibrant, excellent speakers in your session, especially Bella Madam and Dr. Prashant, of course, and Dr. Kuldeep. So, as the scenario of the antenatal care has totally changed nowadays. It's more of the work needs to be done in the antenatal period than intranatal or postnatal period. So these synergy workshop is, I hope, really going to aid skill to the gynecologists, to the postgraduates who have joined today's workshop, today's webinar, and this is going to help them a lot in their future. And with this hope, I wish you all the best, Monica, for all your future endeavors.
Thank you. Thank you so much, ma'am. And thank you for your kind words. Thank you for being here and blessing us on the inaugural webinar. And now I would like to invite, I think Dr. B. Kalpana has not joined till now. Has she, Neetu?
Ma'am, she is on airport having some network issues, ma'am.
Okay,
I
so
just spoke to her. There is some.
we'll wait for madam and whenever she joins, you just...
अभी मीटिंग में है आ नहीं सकते.
So now we will introduce our guest of honor with us, Dr. Savita Tyagi. Dr. Savita Tyagi, ma'am, thank you so much for accepting our invitation. And we are honored to have you here as a guest of honor. Madam is President, Agra OBGY Society, Chairperson of the Quiz Committee of Indian Menopause Society, Scientific Chair, North Zone IMS CON, Chairperson of Rural Committee of IMS in 21 to 23, and past President and Secretary of Agra Menopause Society. Madam has held several executive posts in Agra OBGY Society, which I'm sure must be a very dynamic society under her leadership. She's also
okay, Dr. Monica, it's okay. It's
Thank
okay.
you. Thank you
Thank
so
you
much.
so much. Thank you so much for making me part of this gathering. I am thankful to you very much. And my best wishes to you. You are doing a great work. This is a very important topic which you are covering today. And I'm also eager to hear and learn from all stalwarts who are going to present these topics. And these are very much used in our day-to-day practice. And my best wishes to you. Thank you so much for making me part of this.
Thank you. Thank you, Savita ma'am.
Thank you very much.
Thank you very
My
much.
best wishes to you.
Thank you so much, ma'am. We would be very happy if you could stay on and listen to the great speakers we have. We have Dr. Prashant Acharya with us. I would just like to speak a few words about my three beautiful coordinators. I have with me Dr. Neetu Mishra from AIIMS Bhopal. I have Dr. Purva Bhatkur from GMC Bhopal. I have Dr. Nandini Singh Bhati from GMC Bhopal. These are the three ladies because of which this program has got such a dignified and such a good rapport with everyone around India. So that is why we started to take ourselves away as a brand. And now we no longer are a part of Foxy or ISAR, but we are independently doing synergy. That is the power of synergy. That is the power of our team. Thank you so much, Neetu, Purva, and Nandini. You people.
Thank you so much, ma'am. Thank you so much.
Awesome. Thank you
Thank
so
you,
much.
ma'am.
And now I hand over the session to senior most Dr. Neetu Mishra to take it forward and start the first talk, please.
Thank you so much, ma'am. This is my honor to be with the Synergy team, and we have stalwarts in the field of fetal medicine. The first speaker of session 1, Dr. Prashant Acharya sir. He is Medical Director, Paras Advanced Center for Fetal Medicine, and he will be speaking on neurosonogram at mid-trimester scan. To chair this session, we have Dr. Saida Rizvi ma'am, President Faizabad OBGY Society. She is here with us. And Dr. Sangeeta Chaturvedi ma'am, Secretary Agra OBGYN Society, is stuck in emergency. So I request Monica Singh ma'am to chair this session. Can we have the CV, please? Dr. Saida Rizvi ma'am, she is President Faizabad OBGY Society and very senior practicing gynecologist in Faizabad. She has worked in PMS services as senior gynecologist, medical superintendent, CMS, and AD Mandal Faizabad, Ayodhya. She is also present director of Pulse Hospital, Faizabad, Ayodhya. She is very keen and interested in high-risk pregnancy and infertility. She has received many awards like Red Cross Society Award, Administration and Maintenance Award, Family Planning Award, IMA Award, and whatnot. And we are very honored to have you, ma'am, to chair this session. And I request Dr. Monica Singh, ma'am, our convener of this program, to be the chair of this first session. And I now hand over the session to our chairperson to introduce our speaker, Dr. Prashant Acharya, sir.
Monica ma'am, Dr. Kalpana ma'am joined.
For
Dr. Kalpana ma'am has joined.
Yes, ma'am.
Yeah.
should
yeah.
I go on?
Yes, ma'am. Please proceed with the introduction. Yeah, ma'am. Welcome,
Please.
Kalpana ma'am. I will just take a minute, ma'am. And,
Ma'am, I have to introduce
yes, ma'am.
Dr.
Saida ma'am, please introduce our first speaker, please.
Okay. I have a proud privilege of introducing Dr. Prashant Acharya, a very learned gynecologist, a very talented one, and he is Medical Director, Chief Consultant, Paras Advanced Center and for Fetal Medicines, Ahmedabad, India. Honorary Fetal Medicine Consultant and SVP Hospital, Gujarat University, Ahmedabad, India. And Dr. Prashant is ISUOG Fellowship. He received so many fellowship awards in 2019. And I am proud to say that he is the first Asian to be honored. We feel proud of him, Dr. Prashant.
Thank you
For
very much.
representing our country to some other place. He is board member of trustee
Madam, that is all
2015.
okay. Madam, that's fine. That's fine. It's okay. Thank you.
He is a board member and trustee of trustee 2015 to 2019. He was first Indian to be appointed.
Madam, can you hear me? Madam, can you hear me? Hello.
Yes.
Yeah, that's okay. Thank you very much for kind words because it will take unnecessary lot of time.
Let me say something.
No. It's okay. That's fine. That introduction is great. Thank you very much. Can I share my screen?
Yes, sir. Please, sir. Thank you for accepting our invitation, Prashant sir. I'm really honored and blessed, sir. Thank you so much.
Can you see my screen?
Yes, sir.
I hope my screen is visible to you.
Yes, sir.
Great. Now, thank you very much, Dr. Monica, for inviting me to share my views on the fetal neurosonogram, how to do a fetal neurosonogram during the second trimester, especially during the second trimester. It's an ODE to fetal medicine evaluation in 2024 because it gives you lot of much insight information, and that this is what you will be knowing and you should be doing. So we are going to discuss something about advanced neurosonogram. Before discussing this ultrasound, I would like to tell you that you should know the fetal embryology. At 25 week, the fetal brain is something different. At 17 week, it is different. 15, it is different. And 12 week, it is completely different. Unlike the heart remains the same, whereas the fetal brain changes. So whenever you are doing ultrasound for fetal brain, you should know what is the gestational age which you are evaluating, and that's how you should be performing. There are three basic planes which you should be targeting: ventricular, transcerebellar, and we hardly do transthalamic because does not add a lot of information to our day-to-day practice. So we do these two planes, and there are many things. First is this transventricular plane and one transthalamic plane, that transcerebellar plane. That is what is one primary aim to evaluate. Now in the head, what are the things you should be looking at? One, cavum septum pellucidum. Look at the ratio: cerebral ventricles, choroid plexus, CSP, falx cerebri, cerebrum, vermis, nuchal, fold, cisterna magna, calvarium, sagittal corpus callosum, sagittal vermis. There are many things you should be looking. So let us discuss plane by plane. ISWOG has given in 2007 that you need to see for these three planes. But the things are a little different now. You should be aiming to look at the brain. Now this is 2007, but now they have added. Now what I'm going to show you to 2020, 21 CNS mal for examination. Now they have added few sections, like a coronal section of the interhemispheric fissure, then transthalamic, transcaudate, transthalamic, and also transcerebral plane in a coronal section. Once you add the coronal section, you also add to sagittal as well as parasagittal section. Now look, these guidelines are such that it tells you that this is what you should look minimum. Now, because you should look minimum, and they have added coronal as well as the mid sagittal section, it creates a lot of issues if you are not doing it. Tomorrow, if you have not seen, someone find the malformation, and if they go in the court and say that, look, they have already asked you that you should be looking for mid sagittal section as well as all coronal sections, you have not seen, so you have missed. So aim is to first, you should be targeting your axial scan precisely. You will be able to identify more than 75 to 80%, and adding those 15-20%, these additional plane of coronal and mid sagittal sections, they are going to be utilized. So primarily, second trimester, it is a Paras concept, it's our concept. There are 5 sections you should be looking. First is a transventricular plane. So here you look the lateral ventricles. Then there is one transcerebellar plane. There are 2 transcerebellar plane. One is transcerebellar upper plane. This is transcerebellar lower plane, lower transcerebral plane. One mid-sagittal section and one coronal section. Now what I will explain what you should be looking at every section, why we want to restrict only to these 5 segments. Because during this transcerebellar plane, let me show you the video, what you can do it. This is the axial section which you will be looking for. And if you have learned this section very precisely, I think you should be able to do more than 60-70% of all anomalies in the fetal brain. Sagittal section and a simple coronal section plane going from front to back. This is what is needed, and these are the 5 sections plane which you should be identifying. Before going there, let me show you what the normal anatomy is. If I really look at the fetal brain, this is the midline falx, one hemisphere, another hemisphere, and when I look turn around the fetal brain, this is almost 32-34 Wicker brain. Look at a beautiful sulcation and gyration which are seen. And here, if I turn around, I can see the base of the brain, where this is the tentorium cerebelli. This is the cerebellum, cerebellar body. This is the cerebellar vermis, and this is the midbrain, and this is the optic chiasma. These are the olfactory bulbs. So that is what is a baseline sections of the brain. And coming to your brain from the right hand side here, look at this. This is a classical case of operculization. This is the central sulcus. This is the postcentral. This is the precentral. So these are the sulci, and then if I remove the half of the brain, you will have a mid-sagittal section. In the mid-sagittal section, what you should be looking is, first is the external surface. Is it good? It should not be very smooth. The moment it is smooth, you are talking about the lesion cephali. You should have the cingulate sulcus and cingulate gyrus. This is cingulate, and then what you have is, this is the corpus callosum. This structure is a corpus callosum. This white glistening surface which you see here, that is the cavum septum pellucidum. the surface which you see, this irregular, that is the choroid plexus of the third ventricle. The shape of the third ventricle is technically like this. This is the pituitary, and this is hypophysis, and this is the pituitary or optic nerve, optic tract, which is at this point. You have, this is what your aqueduct is. This area is quadrigeminal plate. So these quadrigeminal plate will have a tectum and this is going to be the tegmentum. Look at a pontine belly. This is the pons. This is the choroid. I mean, this is the vermis of the cerebellum. This area angle is what is known as fourth ventricle. That's the fastigium of the fourth ventricle. And these irregular surface, that irregular surface is the choroid plexus of the fourth ventricle. When you are knowing the anatomy, then you will be identifying the fetal brain like this. Now, how to get these images? First and foremost, this is the brain. This is the skull. That's the brain inside. And when you isolate the angle, isolate the fetal brain from anterior fornix, what you are going to be looking, because it ultrasound has got a typical physics, like where it is going to hit perpendicular, those structures will be seen nicely. Those who are parallel will not be seen that nicely. So if I isolate from anterior frontal, it is going to cover this area. So because it is going to hit these corpus callosum 90 degree, so I will be looking at the brain here like this. So beautiful corpus callosum seen, frontal lobe, and that part of the cortex which will be seen nicely. If I go through the suture line, then this is the corpus callosum and a part of the posterior fornix which is going to be seen, or the posterior fossa or vermis which is going to be seen. And if I go through the posterior fossa, then it is the posterior fossa of the brain which is going to be seen. So it's where you are going to look at the fetal brain. How you are going to look at the brain, that is what will define what kind of information you are going to get. Anterior frontal, posterior frontal, and the suture line. 3 important points, because there are no bones. Because there are no bones, you will be able to see the brain nicely. So you have transcerebellar, transventricular, and this is transthalamic. We don't use transthalamic plane in day-to-day our practice. Now, why is because we will discuss all this part. So a transventricular plane, you should be looking at a BPD, OFD, and HC, posterior horn, anterior horn, CSP width, length, and the cortical width. How to look for these things, and we are going to discuss transcerebellar plane. That's the biometry you should be doing, and a mid-sagittal plane. That's what the biometry of the corpus callosum length, corpus callosum height, vermian height, vermis anteroposterior, and the fourth ventricle size. So that is what you should be looking at, and because if I tell you the biometry here, BPD from out to out, which you measure always, HC you measure, but posterior horn is going to be from here to here, atrium, anterior horn, it is going to be here to here. The width of the cavum septum pellucidum from one septum to another septum, length, the length has to be 1.5 times than the width. If the ratio is reverse, you are talking about either 22q11 deletion or a partial agenesis of corpus callosum. So these are the things you should be looking. And one more thing, from falx cerebri to the cerebral cortex, that is what is known as cortical width. If you are looking at cortical width, that's what you should be looking at. So all in all, you have these many things. Structures are supposed to be seen during the advanced fetal neurosonogram. So like calvarium, falx, CSP, septum pellucidum, lateral ventricle, anterior and the posterior horn, cortex, sulci and gyri, near field of the that BPD section or the brain should not be seen. Anterior complex, posterior complex, germinal matrix, caudate nucleus, lentiform, thalamus. 8 parameters for biometry, suture line, cerebral cortical length, cystic lesions, vascular lesions, shape of the skull. I can go on enumerating those things, but let us try and understand what at least you should be looking at in your day-to-day life. So let me share with you. Let me play the clip, and then this is exactly how we are going to deal with, because tomorrow morning, when if at all you are doing a scan, what you should be looking at. These are the structures. I'll make sure that the clip continues and we discuss in the freeze image. First image, this image is transventricular plane. You see the skull, which is all. If you look at the skull, this skull has to be intact. There should not be any gap. There should not be any gap in the skull. So that is what you should be aiming at, the skull. One of the important clue. Next point, you should be able to see these gap, whatever I'm just erasing right now. This gap or a suture line has to be visible. If there is no suture line, you are dealing with abnormal shape of the corpus, the skull, and scalp dysplasias are going to be there. Then a midline farx. You will have midline white line, which is going to be interrupted in the anterior 1/3. So that is what is one of the main part of the farx cerebri. That is what is going to be there. And the breakage is because of the box-like structure. This box-like structure is known as cavum septum pellucidum. Cavum means fluid filled space. Okay, and that fluid filled space is because of some of the CSF which goes from the lateral ventricle, goes on this side and creates this kind of space and the fluid. You have to measure the width and the length. The length has to be 1.5 times than the width. If it is reverse, if the box is not long enough, then you will have problem. The length is more anteroposteriorly, not on the width. So that is what you should be looking at. Once you are done with that, then look for the cerebral cortex. The cerebral cortex, the black line, that is the cerebral cortex, and it should not be straight. And it is like, if it is straight, it's a problem. So these, what is known as operculization, this gap has to be seen. More is the advantage, more and more that is going to get deepened. Then you have got, this is the anterior horn of lateral ventricle. Look at the shape of the lateral ventricle. So it cannot be straight. The another horn is going to be on this side. The shape is like this. It should not be parallel. It will go broader, like as it goes posteriorly, it is going to get separated. The moment they are parallel, if they are parallel, you are talking about absent corpus callosum. A parallel lateral ventricles, you are facing problems. That is one point. Look, this area of the fetal brain is looking very nice, whereas this area is not that looking very nice because of the mineralization of the bone. That means this bone, which is really good mineralized, it has got a better kind of the mineralization. So it is a hard bone, hard surface, does not allow the ultrasound beams to go in. So it is creating a shadow here, which is a good sign. If you see this brain very clearly, that means you are talking about a possibility of skeletal dysplasia. First is hypophosphatasia, and second, what is known as the osteogenesis imperfecta. So these are the two things which you will have some malformations there. This area, the triangular shape, this area is known as a posterior complex, and it is going to show you some of the sulcation, gyration, and a bit of the corpus callosum here. The shape has to be very, very clear. And this area is known as anterior complex. And in anterior complex, let me tell you, this is the medial wall of anterior horn of lateral ventricle. This is again anterior horn, but what I'm drawing right now, this is also medial wall of anterior horn of lateral ventricle. Here is what is seen is a corpus callosum, and this box which is created here is going to be the fornices. So this area, which is known as cavum septum pellucidum, this red line is septum pellucidi. So that is what a septum pellucidi, because the absent septum pellucidum or abnormal shape of cavum septum pellucidum should lead to many of the fetal brain malformations. So that is what these are the things. Then here is you will have the caudate nucleus and other nuclei which are going to be important to look for this echogenicity. If that is abnormal, think about the fetal hemorrhage there. So there are many things. So looking at a biometry, this is the cortical width. If you look at biometry width and the length, then in the biometry that is going to be the BPD, then OFD, then you will have the complete HC. Then you should measure the posterior horn of the lateral ventricle. You should be measuring the anterior horn of the lateral ventricle. So these are the biometry in one good section. Okay. Now moving to the next section. What we have discussed is this yellow line. If I take this red line for the discussion, I am cutting it from this to this area. In that case, it is going to cut from the cerebral cortex, then the part of the corpus callosum, then the third ventricle, then aqueduct, and this is the upper part of the vermis, middle part of the vermis. This is the inferior part of the vermis. This is cutting from upper part and the middle part. So because it is cutting from the upper part and the middle part, it has got a complete structure of the vermis. So you see here the falx cerebri, you see here the cortex, you see the cavum septum pellucidum, you see the part of the thalamus, because this is here is going to be the thalamus, then the cerebellum. And this cerebellum, which is going to be dumbbell shaped, it has got one hemisphere, another hemisphere, this echogenic area in the middle, that is the vermis, and with this vermis is going to be more echogenic than the cerebellar hemisphere. Then here is the cisterna magna, here is the nuchal fold thickness. So what the biometry which is required is out to out transcerebellar distance. Then you require a cisterna magna here, out to in, and here it is going to be out to out. That is the nuchal fold thickness. So these are the biometries which you should be looking at this. But the advantage of this is here you see the hippocampus, hippocampal sulcus and gyrus, which you will be seeing, parieto-occipital sulcus or a calcarine, which is going to be visible here. Then when I cut, instead of this upper part, if I go for discuss this lower section, it is cutting through the fourth ventricle, and you should be looking at these fourth ventricle, a fluid filled space, because ultrasound, if pass through the fluid, it will appear black. It is exactly opposite than the cavum septum pellucidum. It has got more length than the width. Here it is more width than the length. So that is known as fourth ventricular index. If fourth ventricular index is other way around, look at this is the pathological specimen. Width is more than the length. If the length is more than the width, that means you are talking about cerebellar hypoplasia and other pontocerebellar dysplasia malformations. So think in this line, this much of information, what you are going to get is just simply from your these two clip for just 10 seconds. So tomorrow morning when you go to your clinic, or then please have a look like this, so that you will have much better information about your evaluation. One more clip just to show you. It is not difficult. Take a sweep gradually and then freeze it. Then scroll back and see the fetal structure evaluation, and that is how you should be evaluating. So that's the structure about the caudate nucleus, lentiform nucleus, and the thalamus. So let us see this, and this is how you should be measuring. Near part should not be seen, and the far part should be easier seen. That's what we have. I'm just putting it across all sections. Posterior fossa evaluation, because the anatomy is completely different during whatever posterior fossa evaluation is. So we have quite a lot of, we have discussed this about the posterior fossa. Let me tell you one thing. Now, adding a posterior fossa, let me give you one demarcation: frontal horn of lateral ventricle, cavum septum pellucidum, thalami, cerebellum, cisterna magna. Then you have got nuchal fold thickness, and 7 is going to be the vermis. Now there are simple rules to remember. Whenever you are measuring the cerebellum, the biometry till 24 week TCD, transcerebellar distance, is equal to the gestational age. Okay. So when you measure, you can measure it is like, if you are evaluating at 22 week, it has to be 22. Anything less than 22, please think twice before putting it normal. So if it is abnormal, then you should be targeting you should do a more targeted neurosonogram to identify many malformation. Look at a vermis, look at the symmetry. Both structures both hemispheres are supposed to be quite similar, and then there's going to be an echogenic portion here. So look at, this is the anatomy which you are looking at. This is the cerebellar hemisphere. This is again the cerebellar hemisphere, but look at a vermis. Vermis is completely a different structure, and you should be targeting those right there. Look at the foliation, look at the echogenicity, and this is how you should be looking at. As I told you, it has to be equal to the gestational age. Anything less than that, think about there is a problem. Now, what about the vermis? Vermis is 1/2 than the TCD. That has to be at least 1/2 than the TCD. So if you are evaluating at 22 week, the TCD has to be 22 and vermis has to be 11. Anything less, please always think about something. Then you should be looking at this white line and also this white line and the shape of this fastigium, this triangle. So if you can see these three structures and the length or the height, craniocaudal height, if that is normal, then you should expect that, okay, this vermis is reasonably all right, and you should not be worried about rest of the things as far as this is concerned. Now coming to your mid-sagittal section of the brain, this is the pathological specimen. This is the ultrasound. Just for your knowledge, what is to be seen is the corpus callosum, septum pellucidum, third ventricle, vermis, fourth ventricle, pons, cisterna magna, and let me tell you one important point. Draw a line on the posterior part of the brainstem like this, and make a line along with the vermis. So that line is what is known as brainstem Vermian angle. And another angle is if you draw a line like from brainstem to posterior, that tentorium, like here, the blue line which I have shown here, and now I'm just drawing another line. So that is brainstem tentorium. Here is tentorium cerebelli, and this is the brainstem. So this is brainstem tentorium angle, and here is brainstem Vermian angle. These are the two angles which are important in identification of the posterior fossa cyst malformation whenever you are dealing with the posterior or the posterior fossa cyst malformation. That is septum pellucidum, which I have just drawn right now. So that septum pellucidum will have a lot of issues if you don't find both lateral health, anterior horn of lateral ventricles are communicated, then it's a problem. That's a corpus callosum. That is a septum CSP, cavum septum pellucidum. That is a tila choroidy or a choroid plexus of the third ventricle. That's a third ventricle. And here is going to be, you're talking about the vermis. That's a fourth ventricle. And this is what you'll have a pons, or what is known as, you look for the belly, because pons is little thicker from anterior aspect, and that's what we call as a pontine belly. Look for the cisterna magna. That's what you should be looking for. And in this mid-sagittal section, we are looking for the size of the vermis, elevation of the vermis, rotation of the vermis, lateral ventricular size, and the cisterna magna size. That's what you will be looking at during your mid-sagittal section. So to understand, on the top of the thalamus or the tila choroidy, if you draw a line, this part is the genu, still lower part is the rostrum, then posterior part is going to be body, and that's the splenium. Then you will have the fornicis, which will be seen just like this. So that's the genu, rostrum, body, and the splenium and the fornicis which are there. And these two structures which are now I'm putting it across is anterior commissure and the posterior commissure. So putting it across the mid-sagittal section, you can have lot of information. Just showing you one video, and then because my time is up, I'll be stopping here. Look at a good mid-sagittal section, good corpus callosum, good layers of the cerebral cortex, good size of the tila choroidy, good all the sections of the vermis which is seen here. This is what the superior vermis, middle and inferior vermis. What I want you to see for these two white lines. Let me freeze. Let me go back. So you should be looking at, this is the complete vermis. This is going to divide, these two lines are going to divide superior, middle, and inferior vermis. You should be looking for these three lobes of the vermis, which is practically easily seen here. You are talking about 21 week of the fetus. This is the corpus callosum, which is seen very nicely, and you should be looking. This is the hypophysis, and the optic tract, which will be seen there, and the cerebral cortex with all the layers which are visible. So what I have discussed in this half an hour is just what you should be aiming and what you should be targeting during your day-to-day examination. So I hope, Dr. Monica, I have justified your faith, and I wish you are going to make difference in the life, and all the best for the whole webinar series of Synergy. Thank you very much, Dr. Monica.
Thank you. Thank you so much, sir.
Thank you, Dr. Prakash. Thank you, Dr. Acharya, for such a informative lecture. It was really brainstorming. And I want to ask you one question.
Yeah.
Whether it is available at Lucknow or
What
nearby
is
places,
available now?
or what is the cost of this neurosonogram?
Cost, what I am charging something?
No, not you. The sonologist will take how much amount so that patient can afford or not?
There is no question of they should be doing this. It is not about if they are not doing, you should not send it to those radiologists or gynecologists or sonologists. They have to do it. It is incorporated as a part of the screening. They should not charge something which is extra. Okay. It is a part of your ultrasound scan. It is not anything extra. It is a routine. What I have discussed is just a routine scan for everyone.
Thank you. Thank you so much, sir.
Excellent,
Thank you
Dr.
very much.
Prashant. Very elaborative, very nice presentation. मैं आपको बोलने से रोक नहीं पाई. So, according to you, this is a part of anomaly scan. This
Yes.
neurosonogram.
Yes. It is a part of anomaly scan.
Anomaly scan, and every sonologist has to do it.
Everyone. It is their duty and liability. I would put it as a liability. If they don't send you these images, you have to say them, I will not refer it to you unless you give me these images.
Okay. Thank you. Thank you.
Sir, you're very right. You have correctly said that every gynecologist should know how to interpret the images herself or himself.
Yes.
The time has come. Sir, there's a question in the chat box. How early can we diagnose hydrocephalus?
Hydrocephalus, 12 weeks, 13 weeks, you can diagnose hydrocephalus.
So,
some
sir,
other conditions can lead to that hydrocephalus that early.
So it is the lateral ventricular dilatation also which progresses to hydrocephalus.
It depends upon the condition, underlying cause. Ventriculomegaly has got total 60 causes why it can lead to ventriculomegaly. And severe ventriculomegaly, we call it as a hydrocephalus. Hydrocephalus is when lateral ventricle crosses 15 millimeter, or somebody says 20 millimeter. Okay, so it's a ventricular enlargement. Now there are many reasons for ventricular enlargement. So you should be looking at why it is enlarged, and then go for the root cause, and then go for the treatment investigation. Try and investigate why it happened, and is it going to recur or is it not going to recur. You should be looking for those kind of things.
So how early should we do the neurosonogram?
There are two ways. First doing at 13 week, and then at 22, 23 weeks. 13 week has to be all complete neurosonogram has to be there.
Yes,
sir.
13 week scan is not for NT-NB. No, it is dead now. Nuchal translucency is dead. It is going to die in couple of years. The NIPT will take over nuchal and nasal bone. Is going to die.
Sir, anencephaly can be diagnosed in first trimester.
10 weeks. 10 weeks.
10 weeks.
Yes.
Thank you so much.
So it is
Thank you so much, sir.
It is so encouraging. Our senior members are taking so much interest in neurosonograms. Saida ma'am, you are the trailblazer. You have to spread all over
Monica,
all
for
the
inviting me.
Yes,
and I thank all the organizers from my heart and soul. And I want to take leave because I am having one emergency. So please excuse me.
Thank you so much, ma'am, for joining. Thank you, Prashant sir, for the wonderful talk. And I'm always obliged to you for these sessions, sir.
Thank you. Thank you.
Keep blessing us, sir, in the same way. Thank you, sir.
Thank you. Thank you.
Thank you, sir. And now I would request Dr. Purva to kindly start the session 2. We just have to see whether B. Kalpana ma'am is there, because we had to invite her for guest of honor. I think madam is still traveling. So we can
Madam
start
left,
from
ma'am.
session two.
Huh.
Ma'am,
Yeah.
left.
Start session 2. Purva, over to you.
Thank you so much, ma'am. Carrying forward the to the second session, that is twins basic of NT scan and aneuploidy screening. I invite Dr. Bela Bhatt, ma'am, for the talk, and I invite Dr. Ikika Singh, ma'am, and Dr. Meeta Chauhan, ma'am, for chairing the session. Dr. Ikika Singh, ma'am, madam is presently President Mao OBGY Society. She is member of Management Committee ISAR, Executive Member UP ISAR State Chapter, and North Zone Coordinator Foxy Young Talent Promotion Committee. She has been doing very much research works and has lot of publications and awards to her credit. Among them, the champion of ISAR Wonder Foxy Award, Foxy Unsung Hero Award, Health Icon of Varanasi, and many more. We welcome you, ma'am, to chair the session. Next, we have Dr. Meeta Chauhan, ma'am. Dr. Meeta Chauhan, ma'am, is presently Secretary Mao OBGY Society, and she is Director of Jeevan Jyoti Hospital. We welcome you, ma'am. Now I hand over the session to the chairpersons for introducing our speaker, ma'am.
Thank you very much, Dr. Purva, for your kind introduction. And yes, the speaker whom I'm going to announce is one of the person whom I have met, a very comfortable, intelligent, and a smiling lady, and wonderful concepts. And besides all those qualities, she is a lead consultant at Bela Women Hospital and Fetal Medicine Center. Also a lead consultant at Dr. Baba Saheb Ambedkar Memorial Central Railway Hospital. She is FMF UK certified sonologist for fetal abnormalities as well as for nuchal scan, life member of SFM, joint secretary of AFG Mumbai, managing counseling member ISPAT, and she has received CS Dewan first prize at AICOG 2018 Bhubaneswar. Besides that, she is winner of first prize Foxy Has Talent National Competition, national convener of Foxy Superstar Competition, national talent coordinator Foxy Has Talent, and she has won.
That's fine, I think.
No, Dr. Bela, I think I can talk a lot. And beside all this, I want to say you have such a beautiful grace when you are on the stage. Whether it is dancing, and I hope you are going to, crack it in the session also. So over to you, Dr. Bela.
Thank you so much for the sweet words of introduction, Dr. Ikika Singh. At the outset, I would like to, I'll share my screen first. Can I share? Okay, just a couple of seconds. Yeah. I'll have to just. This is coming in the way. So. Okay. Okay, hope you can see my screen.
Yes, very much.
Yes. So, it's a pleasure to be part of this wonderful webinar, which is convened by none other than Dr. Monica Singh, a dear friend, and she has been doing excellent academic activities the last entire year. I have witnessed that. And also good to see so many friends here from Agra, Faizabad, Mao Society, the Association of MP OG Societies, which was introduced to me today. Yes, you are doing brilliant activities. And of course, there are so many friends and familiar faces that I see here today. And so it's an absolute pleasure for me to be part of this. And of course, an honor to share the platform with someone like Dr. Prashant Acharya, whom we all look up to for wonderful fetal medicine talks and work that he has been doing. So, well, after this, the detailed talk of neurosonogram, I'm going to drag you back to the basics of nuchal scan, and that too for twins. Okay. So, well, we have all learned a lot about what to look at in the nuchal scan in the singleton pregnancy. But then what about twin pregnancies, right? So
there are few important concepts that's very, very important for everyone, those who are doing scans on their own, those who are sending to sonologists. Few of the concepts are such that you must know of, and I hope that by the end we'll be clear about few important aspects of the same. Now, first thing that we must understand as far as twins is concerned is that zygosity is different from chorionicity. So a dizygous fetus will always be dichorionic with either separate placenta or fused placenta, but a monozygotic twin can either be dichorionic in 24% cases, or in the rest 75% cases it can be monochorionic, out of which if the splitting occurs in less than 5 days, it will be dichorionic. Between 5 to 8 days, it will be monochorionic. And very rarely in 1% cases, between 8 to 13 days, it will be monochorionic, monoamniotic. And beyond 13 days, as we all know, it will be conjoined twins. So this is the basic thing that we must know about twins. Now, as far as twins are concerned, the first trimester evaluation or the nuchal scan evaluation is one of the most important aspects of managing multiple pregnancy. Why? Because there is a checklist that we are all going to follow at this nuchal scan, which is done between 11 to 13 weeks, 6 days. So what is this checklist? We're going to look at the number of fetuses, dating of pregnancy, determining chorionicity and amnionicity, labeling of twins, screening for aneuploidy, screening for structure anomalies, screening for pre-eclampsia fetal growth restriction, and screening for preterm birth. So let's look at each aspect of this. Number of fetuses. So of course, when we do early pregnancy scan, we can always look at in very early pregnancy, at times we see two distinct gestational sacs, as you can see in this particular video clip, which will tell us that, yeah, there are two different separate sacs, and this has to be dichorionic pregnancy. Sometimes very early on in monochorionic pregnancy, especially very small, less than 6 weeks, 5 weeks pregnancy, you may see just one fetus, and then as the pregnancy grows, maybe you'll be able to see. Sometimes that may happen in monochorionic twin. And another important aspect is vanishing twin. Again, I'm sure those who are doing IVF, those who are doing early pregnancy scans must be seeing that early in the pregnancy, around 6 weeks, you may have seen that 2 or 3 fetuses that you can see, but as the pregnancy progresses, at 10 weeks, at 12 weeks, maybe one fetus has vanished. And now why it is important to document in your reports? Because when it comes to screening for aneuploidies in those twins, then it becomes very, very important, how we'll see when we talk about the aneuploidy screening. Second important aspect is dating of multiple pregnancies. So how do I date these pregnancies? So there'll be some pregnancies which have naturally conceived. There'll be some which are conceived out of IVF. So when it is naturally conceived, in that case, I will look at the CRL out of 2 twins. The larger of the twin is one, which will be taken as the date will be used for the dating. So as you know, like singleton pregnancy, in twins, the basic concepts are same. The CRL has to be taken in the standard manner, how we take in the singleton pregnancy. It has to be a mid-sagittal section, a clear crown and rump has to be seen, and you should be, the fetus has to occupy at least 75% of the screen, and then you have to take your CRL measurement, because this only if the CRL has been taken in this standard way is it going to be useful for dating of pregnancy. So even if you are not doing scans on your own, when you get a report from a sonologist, it is a duty of an obstetrician to check the image. Only if it is standard image, then it should be acceptable and it should be used for dating and not otherwise. So that's why it's important for us to know what is a standard image. So spontaneous conception, we have already discussed. Now, why do we take the larger of the 2 CRLs at twins? Because if you take the smaller one, then you may miss the diagnosis of fetal growth restriction, which still can be there at nuchal scan. Sometimes some of the trisomy 18, 13, you may find that the fetus is smaller in CRL. But large for gestational age at first trimester scan is a rarity, and therefore we always take larger of the two CRLs for dating, and the other one is always considered abnormal. Now, suppose the pregnancy you get after IVF, which is very, very common these days, you'll get multiple pregnancy, twins, triplets. Now here, we already know the date of conception or date of transfer. From that, we can precisely calculate the EDD, which has to be fixed at nuchal scan. And then throughout the pregnancy, we just monitor the growth based on that EDD. Now remember, date of conception is not equal to date of transfer, because we know that there can be day 3 embryo transfer, there can be day 5 embryo transfer. So you have to minus these 3 or 5 days to get exact date of conception, and that should be put in the your machine for the data to calculate the EDD. So these are basic but very important aspects, because your dating is to be determined at your nuchal scan of twins. Now, why do we want to do proper dating? Of course, we know that fetal growth restriction in multiple pregnancy is more common than singleton, right? In dichorionic, 10.5%, monochorionic, even more common, almost 20%. And once we decide the EDD at nuchal scan, every time the machine is going to give you EDD, but please do not mention in your report about EDD in every scan. Just mention of the centiles of growth later on after nuchal scan. Second importance of dating is we know that the chance of preterm delivery is very high in twins. So unless you have dated your pregnancy well, how do you know how many weeks pregnancy it has reached, whether it's 32 weeks, whether it's 34 weeks, whether it's 37 weeks? Only if you have done a precise dating, you'll come to know this. So this is also again very, very important, because we'll be taking many decisions based on your maturity. Now, the third and very, very key, crucial important aspect is determining the chorionicity and amnionicity. Now, remember, out of the checklist that I have told, one single parameter which nobody should ever miss is determining the chorionicity. Remember very well that Nicolaides has said there is nothing like a twin pregnancy. There is a dichorionic twin pregnancy and there is a monochorionic twin pregnancy. The term twin pregnancy is now obsolete. We do not use it, right? So you have to decide right in your early pregnancy at 3rd month, whether it's a dichorionic twin pregnancy or a monochorionic twin pregnancy. And how do we do that? With the help of T sign and lambda sign. So you can see here very well that there is a chorionic tissue which is going in between, insinuating in between in the, like a triangle in between two fetuses. And this is a lambda sign, which tells you for sure that this is a dichorionic pregnancy. And you'll be able to see this very well till 14 to 15 weeks of pregnancy. Now, not only just you have to see that there is a lambda sign and this is dichorionic pregnancy, it's very, very important to document this and give this image to the patient and tell that, look, both the babies are having 2 separate placenta or 2 separate kitchens from where they're going to get food throughout pregnancy. Now, the second thing is T sign. What is T sign? Where the membrane is directly inserting onto the placenta, but there is no chorionic tissue which is going in between the membranes. And this is known as T sign. And this tells you for sure that this is a monochorionic pregnancy where both the fetuses are sharing the same placenta. And that's very important, because why is it important to understand, and why I'm hammering that always mention about chorionicity? Because the entire monitoring of twin pregnancy is going to be based on whether it's a lambda sign or a T sign, whether it's a monochorionic or it's a dichorionic pregnancy. Because when the 2 placentas are separate, the complications are little lesser. Whereas when both the twins are sharing the placenta, there are vascular anastomosis, which is going to lead to many vascular complications like twin-to-twin transfusion syndrome, TAP, strap, and this is to the tune of 26% in monochorionic pregnancy, which will not be there in dichorionic pregnancy, and therefore it's very important to document that whether it's monochorionic and dichorionic. Because in dichorionic, this is again ECOG guideline, which tells us that in dichorionic pregnancy, we can monitor every 4 weeks, whereas in monochorionic, it is mandatory to monitor after 14 weeks, every 2 weeks with the parameters mentioned. So unless until you have diagnosed whether it's dichorionic or monochorionic, how are you going to tell patients how frequently patient is should come and how frequently we are going to do the Dopplers and growth and everything in the pregnancy, throughout the pregnancy. So the patient should also be educated whether it's dichorionic, monochorionic, and it's very, very important to keep a soft copy with you and give a hard copy to the patient and tell the patient that in case, because we know in our country, the patient may move from one to the other sonologist and to the other third one, may move from one city to the other city. So it's important for them to tell the sonologist, show these images and tell that whether it's a dichorionic or a monochorionic pregnancy, because then it is easier for the sonologist to monitor. So I will go to the extent of telling that it's a crime not to report about chorionicity at nuchal scan. It must be mentioned and documented. Now, what is the importance of this? I'll just quickly give you one example of a case. This patient was referred to me at 24 weeks pregnancy as monochorionic pregnancy. MCDA twins with twin-to-twin syndrome stage 1, TTTS stage 1, for the opinion of in whether the patient requires laser treatment or not, right? Now, look at this report. It shows here that it's 24 weeks, MCDA twin, poly, oligo, and it's a stage 1 TTTS, and whether it requires the laser or invasive treatment. Now, the first thing that we do whenever we get a patient like this is looking back whether patient has any first trimester scan, whether patient has any nuchal scan reports, and then we try and, because I need to confirm whether it's really a monochorionic or not. And at 24 weeks, I cannot. But usually by 15, 16 weeks, you can see the lambda sign and T sign. After that, you cannot. And that's the reason it's important to document a nuchal scan, right? After that, it may all look same, right? So I wanted to look at the images. Now, the patient had a scan at 21 weeks, which just showed that it's a monochorionic diamniotic twins, but there were no images which were available, one thing. Then the patient was also carrying a scan report of 13 weeks. Again, look at this. Now, this 13 weeks tells again monochorionic diamniotic. Again, patient did not have any images of this nuchal scan or 13 weeks, which is very crucial, but patient was not having any images. Luckily, the patient had one image of 6-week scan, if you can see this, very early pregnancy, where you can see 2 distinct gestational sac, right? This is 2, right? This is 6-week scan, but luckily it is showing 2 distinct sacs. So I know for sure that this is a dichorionic pregnancy and not a monochorionic pregnancy at all. So the question of vascular complication or TTTS doesn't arise here, right? So actually it was a dichorionic pregnancy, but was mentioned as monochorionic pregnancy. So question of TTTS doesn't arise. There was no oligopoly also, but more important was it was a DCDA pregnancy. So patient was counseled that you need to get monitored every 4 weeks with your growth and Leica and Dopplers and all, but not to worry about TTTS, but because vascular communications are not there in DCDA, and so it's not going to happen. The patient after 24 weeks went to the periphery from where the patient had come, got monitored well till term, and then delivered normally at full term, and then it showed that it was a one girl and one boy patient delivered. So that tells for sure that this was, and there was no vascular complication because it was a dichorionic pregnancy. So what's very, very important here is, if had they been given the proper lambda sign, which must have been there at 13 weeks, 11 to 13 weeks, then the things would have been clear that it's a DCDA pregnancy, because the patient had so much of anxiety and had come from periphery to Mumbai just to, get confirmation whether any invasive treatment, which is not a simple treatment, which is required. So that's the importance of documentation and of chorionicity. Now, the other important aspect is labeling of pregnancy. Now, again, labeling of twin pregnancy is extremely, extremely important. It should be documented clearly in the reports. Again, you get a lot of confusion because one sonologist will label as differently and the other one differently. So it's better to label, show it in the images also. And how do you label? So either the orientation of the fetus is maternal left and right, or upper and lower. The one which is closer to the cervix is lower, and the one which is away from the cervix is upper. So orientation can be either ways. So in case of twins, you can mention as maternal left, and is twin A is one is maternal left, maternal right, twin 2 is right, or the lower one is twin 1, the upper one is twin 2, or there are other criteria also. So you can always mention about the location of placenta. So if they are dichorionic pregnancy, one placenta may be anterior, the other twin placenta may be posterior. Then the insertion of cord may be different in both. In one it may be central, and one it may be marginal. If there is any kind of structural anomaly or any marker or growth disorders, again, everything should be mentioned, twin A with this, twin B with this. So more the merrier, more are the criteria to label the twin. Better it is even if the patient goes to the other sonologist, or if with the same sonologist, if there is suppose there is one fetus with fetal growth restriction, if they have to monitor, they know whether it's twin A or twin B which is affected, and they can monitor them well on follow-up. So it's extremely important for monitoring of fetal growth, in structure anomaly. If invasive testing is needed, it's so important, whether it's fetus A, which is having structure anomaly, and B, because you have to label the samples also accordingly, and you should know which is the affected fetus and which is looks normally on scan. TTTS, which is likely to be the donor, which is likely to be recipient, TAPS, anemic, polycythemic. So all these criteria will make things very, very clear. There's one phenomenon which is perinatal switch phenomenon, which we have, again, even if you are labeled in early pregnancy, you must remember that orientation may change as you go from first trimester to second trimester to third trimester. Sometimes a fetus which is close to the cervix may move away. There can be liquor in the other set, which is little larger, may go close to the cervix. And so everything has to be kept in mind, especially if the cesarean section is decided at term. Remember, fetus A, which is close to the cervix, is not going to come out first. It is a twin B which will be closer to the skin, so that will come out first. So if at all there is some anomaly in either of the fetus, it has to be told to the neonatologist which fetus will come out first. So these are very, very important aspects which are to be kept in mind as far as twin pregnancy is concerned. And now we go to another important aspect, that is screening for aneuploidy. Now, we know that in twins, screening for aneuploidy is little complex, and how different it is from singleton pregnancy, we'll just see now. So screening method, again, it can be just nuchal scan. It can be combined like nuchal scan plus double marker and NIPT. So screening method, standard way of taking CRL, nuchal translucency, nasal bone, you have to use the standard images, and it has to be done in a standard way. But we also use the other markers like ductus venosus. We all know the A-wave reversal is one of the markers, the tricuspid flow, the tricuspid regurgitation is one of the markers. All the 4 markers that we look at in the nuchal scan are we going to use in twins as well. Now, how is it different combined test in singleton and twin pregnancy? So remember, in DCDA twins, there'll be 2 risks, because we know there are 2 possible different chromosomes in these fetuses. And so based on 2 different entities of twin A and twin B, we'll have 2 different risks in DCDA. Whereas in monochorionic twins, in majority of the cases, the chromosomes of the both twins will be same, and therefore there'll be a single risk per pregnancy. The risk will be same for both the fetuses based on average NT of both the fetuses. That's how we calculate in monochorionic twins. Now, as far as biochemical markers, double marker, beta-hydroxygen papain is concerned, in twins, adjustment is required whether it's dichorionic twin or monochorionic twin. This adjustment is done by your lab. which is going to do the biochemistry. And therefore, it becomes very, very important for us to mention in the form whether it is singleton or twins, and also mention the chorionicity, whether it's dichorionic or monochorionic, because accordingly, the lab has to adjust for the MOM. If you do not do the same, then you will get a wrong risk calculation. So from our point of view, it's important to mention this in form, because many a times this is not mentioned and then you will get a wrong risk calculation. As far as detection rate is concerned, a combined test for dichorionic is 86%, for monochorionic is around 87% with false positive rate of 5%, little lesser than for singleton pregnancy. But as far as false positive is concerned, it is slightly higher in monochorionic twins as compared to dichorionic. Why? Because we know that increased NT in the first nuchal scan in twin monochorionic twin can be sometimes an early manifestation of twin-to-twin transfusion. So rather than aneuploidy, the higher risk of aneuploidy, it can be just because of the early TTTS, and therefore the false positive could be slightly higher in monochorionic twins as compared to dichorionic. But remember, NT in multiple pregnancies is not just a marker for aneuploidy. If there is NT discordance of more than 20%, there are higher chance of developing TTTS with a sensitivity of 64% and specificity of around 80%. If there is abnormality in ductus venosus, there is AVAV reversal, tricuspid regurgitation, then the likelihood ratio for twin-to-twin transfusion is 21 times higher. The risk increases by 21 times. So we look at all these markers, not just as a marker of aneuploidy, but also as a marker for early TTTS, and therefore we have to keep a watch on all this. As I said, it's important to label that it's a vanishing twin, because in aneuploidy screening, how do you do? Suppose you are seeing two sacs. One viable fetus is there. Suppose both are viable in twins, then of course, as I said, combined screening can be done. Now, out of the two sacs, if there is one viable fetus with viable heartbeat is present, the other sac is completely empty. There is no CRL which is seen. Then again, you can do a combined test. But if there are two CRLs seen, in one you can see heartbeat, the other one is a dead fetus, then please do not send for your double marker. You just have to do a nuchal scan based risk calculation, because this beta-hCG Pape of the dead fetus can alter the risk calculation of biochemistry, and therefore we do not do it if it's a vanishing twin with one dead fetus, which is seen on scan. As far as NIPS is concerned, well, in monochorionic, the sensitivity is same as singleton, trisomy 21 as good as 99%, but dichorionic, if the fetal fractions may differ. So if there is affected fetus with a lower fetal fraction, then it can be falsely negative. However, ACOG still tells that NIPS is a good screening method for twins. Why? There is a reason, because we know that NIPS has the least false positive ratio rate as compared to combined screen, and therefore will require less number of invasives. Now, in twins, we know that if invasive has to be done, the chance of abortion are high. We have to put in 2 needles. As such, in twins, abortion chance is high. You put in 2 needles, slightly higher chance of abortion of these invasive methods. So NIPS is something in which the false positive is less. So you'll need less invasives, and therefore NIPS is good for twins. Now, as far as invasive testing is concerned, as I said, the orientation and labeling of twin is extremely important. The amniotic fluid, the samples that you take also has to be labeled very, very carefully, because the one which is affected has to be labeled and conveyed to the laboratory which one is which. So labeling, whether it's twin A, B, 1, 2, has to be very, very important. Now, as we do in singleton, again, we do ultrasound screening for structural anomalies. Now, in dizygotic twins, the risk for structural anomaly is 2 to 3% per pregnancy. But in monozygotic, it is 2 to 3 times higher, as high as 10% in monozygotic pregnancy. Risk calculation for preeclampsia, well, we use the same parameters that we use, that is the mean uterine artery PI, which is along with the maternal demographic factors and PLG et al. You are doing can tell you about the risk for that. As far as preterm birth, we know that the gold standard duration time is 18 to 4 weeks. And if the cervical length is less than 25 millimeter, then it's a moderate risk for preterm delivery before 34 weeks. And if it is less than 20, even in asymptomatic at 20 to 24 weeks, is more accurate predictor for preterm birth. But if at all at nuchal scan you find on your transvaginal, if you are doing and you find it's a shorter, then maybe you will keep a closer watch on this and look at these fetuses at 18 to 24 weeks closely. Last but not the least, if there is a single device in twins in first trimester, very early, 7 weeks, 8 weeks, is there any other risk to the other fetus? No, there is no increased risk when there is demise, which is so early in the pregnancy. So, well, friends, I'm sure you know now the checklist of all the things we have discussed. I'm not going to repeat. Again, I'm emphasizing the most important things and which should never be missed if you are doing a nuchal scan is determining a chorionicity and amnionicity and document. So even if the sonologist is giving you the report, do not accept it if it is just mentioned as twin pregnancy. It has to mention dichorionic and diamniotic. And friends, also ask for the image, clear image of lambda and T sign, and then only you can say that this is a dichorionic or amniotic monochorionic pregnancy. So, well, friends, throughout my tenure of 3 years as a chairperson for the Imaging Science Committee, I have always tried to see that every obstetrician and gynecologist becomes a sono obstetrician and a gynecologist, because you know that every patient that walks in your chamber needs ultrasound, for whether it's aneuploidy screening, whether it's twins, it's singleton, it's growth restriction, anything you need ultrasound. And therefore, I'm sure this kind of webinars that Dr. Monica Singh, the AP, the all association of MPOGs are doing is going to be extremely helpful to all of you, all of us. So I think with this, I'll conclude. Hope I haven't taken extra time.
No, ma'am, you were absolutely on time. In fact, you are 3 minutes early, ma'am.
Thank you.
So we have plenty of time. Kika, you can please coordinate the questions, answers, please.
Thank you, Dr. Bela. And as I really said, you rocked the stage and you have rocked this also. And you have put every clinical point so simply and so beautifully that, yes, this is what basic gynecologists always have a problem with, to know the chorionicity and to know whether it is really MCDA or it is DCDA. Most of the twins are DCDA, and this is how the difference has to be made, to know the lambda sign and the T sign. I mean, that is the scan which is very much necessary to point out everything. I just wanted to ask you 2 things. One is, you already mentioned that if the other twin demise is in the early trimester, then it's not much of a problem. But like if the fetal demise occurs in the second trimester or the late first trimester, so how is that? I mean, in DCDA also, does it affect the surviving twin, or it is only in the MCDA that MCDA or MCMA, it is the surviving fetus?
It's a very good question, because as far as DCDA is concerned, we know that they have a separate placenta. So even if there is demise of one fetus, it's not going to affect the other fetus, because they do not have vascular communications. So that is not going to affect. We are not worried even if there is demise of other fetus. We'll try and try to reach up to 37 weeks for the other fetus to reach to the maturity. So that the counseling of the patient is extremely important. Monitor the fetus very well. That is what is important. As far as monochorionic pregnancy is concerned, it's definitely a problem, because the minute there is the demise of one fetus, the blood is going to rush from the normal fetus to the dead fetus, and there's going to be hypotension in the other fetus which is alive, and there's this hypotension and the low pressure in the blood vessels in the brain is going to some changes in the brain of the surviving fetus as well. But again, if you have already seen on the scan that one fetus is dead, the other is alive, whatever damage has to occur has already occurred, because it occurs instantaneously within few hours of death. So if you have already seen, then what you are supposed to counsel to the patient is that you will monitor the other fetus, of course, for the MCA PSV, because that will tell you whether that fetus is becoming anemic or not. And doing a good fetal neurosonogram, as Dr. Prashant Acharya has beautifully explained, whether there is any changes which is happening in the brain, and to counsel the patient very well that exactly will not come to know about the functioning of the brain of the surviving fetus. Maybe MRI can help you to some extent. The neurosonogram followed by MRI in the 3rd trimester may help you. But yes, there will be some gray area which will be there, and that has to be accepted by the patient, because now doing something is not going to help. Whatever damage has occurred. So if delivering that premature baby is going to cause more damage to that preterm baby. So better to monitor that with neurosonogram, MCA, PSV, anemia if there is at all, then correction and all is what is required.
And how frequent that monitoring should be?
Depends what is the MCA, PSV there. If it's normal, then maybe initially you can do weekly monitoring of that fetus. Neurosonogram, if you feel that it looks okay, then maybe after 2 weeks, 3 weeks, you can repeat and see if there are any changes. But then counseling becomes very important, because parents need to know that the other fetus already some damage could have occurred.
And one thing I wanted to ask was, what is that you see in TAPS? In TAPS fetuses, what is that has to be looked
Anemia,
for?
polycythemia.
Yes.
So in that, that is something where we monitor the, as I said, in monochorionic pregnancy, that's the reason we monitor with Dopplers and growth and everything 2 weekly.
Yeah.
So in that we look at the MCA, PSV, MOMs. So if the difference, the more than 1.5, we know mm, we know is the fetus is going to be anemic. When it is less than 0.8, it is going to be polycythemic. So that much is the difference. Then we know that these occurs when there are small arteriovenous connection between, or artery to artery connection, which is causing not major pressure difference or Leica or bladder differences, but there'll be hemoglobin difference, and then the entire management is different then based on the MCPS.
Thank you very much. Since you made everything so clear, Dr. Bela, but these are the few points which always used to be, some kind of a confusion, and it's been cleared very nicely. Every 2 weekly when it is MC monochorionic, and every 4 weekly scan when it is dichorionic. That is the goal.
Again, that is very important for obstetrician to remember also if they are monitoring, because that frequently the patient has to be sent to sonologist.
Yeah. Okay. Thank you very much.
And with your permission,
Monica.
Bela ma'am, I would like to tell all the interested audience over here that ICOG and FMF India, FMFI, have got very nice training modules at regular intervals. I was also a student of one of these modules. Bela ma'am was one of our faculties. So FMFI and ICOG, they collaborate to create a very nice training modules of OBGY plus basics of fetal medicine for all interested Foxians who can join the modules and study from all the great stalwarts. Thank you so much, Bela ma'am, for the beautiful talk. And it's always a pleasure to hear you and see you, ma'am. Thank you so much. Over to the third session. Dr. Nandini to coordinate.
Yes, ma'am. Good evening to one and all. Moving to our third session, which is on first trimester screening by a very well-known speaker, Dr. Kulbhushan Vishnoi, Service Director and Consultant Radiologist at Varka Scan. The session will be chaired by our chairperson, Dr. Kalpana Yadav ma'am, who is the head of Gynae Department of SSMC Riva. Unfortunately, Dr. Manjushri Pandey ma'am is unable to join us. And next chairperson, Dr. Dipti Gupta ma'am, she is the secretary of MPOX. Moving to her CV, Dr. Kalpana Yadav ma'am, madam is chairperson of the State Perinatology Committee. She is also the vice president of Riva Obstetric Society. She has been a great academician and published has 19 research articles, national as well as international journals. She is a master trainer of MMA, CAG, BMONC, EMONC, TGA, and LEAP. She has received second prize for her research paper in maternal conference, UG and PG examiner, and a thesis guide. She has received appreciation award for her outstanding services in maternal health by Honorable Speaker of MP Government. She has worked for adolescent health and anemia as the co-chairperson of Mission Pink Health in Riva. We welcome you, ma'am.
Thank you, Dr. Nandini. Good evening to all respected esteemed members of this webinar on Pulse of Fetal Medicine. First of all, I would like to thank MPOX and organizers of this webinar, Kavita Singh Madam, Monica Singh Madam, and Dr. Deepti Gupta for giving me the opportunity to be a part of this prestigious program. First trimester scan is very useful and important to understand by every obstetrician. It's my pleasure to introduce the speaker of this session, Dr. Kulbhushan Bishnoi. At present, he is working as director and consultant radiologist at Varkha Scan Center. Talking about his educational qualifications, apart from MBBS and MD radiodiagnosis, he did fellowship in fetal medicine and certified course on anti-NB scan, anomaly scan, and Doppler study. Currently, he is working as senior resident at Maltas Institute of Medical Science and as consultant at Varkha Scan Center. He is also actively involved in research work. Now it's over to you, Dr. Kulbhushan. Please impart knowledge to all the delegates on first trimester scan.
Good evening, everyone.
Dr. Kalpana ma'am, with your permission, Dr. Deepti is also chairing the session. So, Dr.
Yes.
Deepti, Dr. Nandini, could you please welcome Dr. Deepti for the session?
Yes, ma'am.
Yeah, yeah.
We can have a CV, please. It's a proud privilege to introduce the Secretary of MPOX, Dr. Deepti Gupta Madam. Madam is a consultant and unit head of Ankur Fertility Clinic, Jabalpur. She is also the Associate Professor at NSTV Medical College, Jabalpur. Madam is Secretary of MPOX. She is the immediate past Secretary of JOBS, that is Jabalpur Obstetric Society. Madam is West Zone Coordinator of the Foxy Quiz Committee and a National Corresponding Editor of Jogi, also a peer reviewer. She is a co-editor of Foxy Focus on RPL and MPSR and MPAGOI Executive Committee member. And it's a privilege to have you here. Please chair the session and kindly introduce sir.
So I think sir has been introduced. Dr. Kulbhushan has been introduced. Dr. Kulbhushan, please feel free to share your slides now, please.
Yeah, can you see my slide, ma'am?
Not yet.
I've shared my screen.
No, I don't think we can see your slides. We are just seeing our names, all the. Yeah, now we started seeing your slides. We can see the slide now.
Okay.
You can put it full screen, please.
Yes. Yes. Now, can you see my slide?
Yes, Dr. Kulbhushan.
Good evening to everyone present here. Thank you so much, Dr. Monica Singh ma'am and Team Synergy for giving me this opportunity. And it's a lucky day for me that I've shared the platform with Dr. Bela ma'am and Dr. Prashant Acharya. So, I'm Dr. Kulbhushan Bishnoi. I'm from a small district in MP and I work at Varkha Scans Private Limited. Today, I'm going to talk about first trimester screening. So let's begin. Before we begin, I would like to ask a small question. If anyone is willing to answer, you can unmute yourself and just reply in yes and no. So the question is that there is an average Indian individual and the weight of the individual is 50 kg. So is it an okay weight for an Indian individual? Anyone? Or is it less or more?
Male or female?
You can take a male.
Yes.
Okay, if it's a yes from everyone, agree. But did I tell you the age of this average Indian individual? Suppose the age is 4 years. For a 4 years, 50 kg is fine weight? No, right?
No.
Definitely not. So see, the entire thing hinges upon age. And what we are talking about, the maternal age and the fetal age. So maternal age we have to collect because increased maternal age is associated with increased risk of Downs, and that is the premise of screening. So that is why we need an appropriate accurate maternal age and an accurate fetal age, which can be estimated by CRL. And how do we do a accurate CRL? As Bela ma'am has told us in the last lecture, also with CRL, we have to look at this anatomy. So you go through this ESOC guidelines, which are easily available on online, where how a first trimester scan is done and what are the sections to be taken as must. So why a CRL is important? Firstly, we'll know how to take a CRL. The CRL we have to take in a mid-sagittal plane, strictly through the crown to the rump and the genital tubercle. Calipers should be well positioned and the head is in neutral position with fluid within the chin and the neck. The cord insertion should be seen, nasal bone profile should be seen, and the spine should be posterior. You can see my slide?
Yes, sir.
Yes. So spine should be posterior. And this is the most accurate measure of fetal age. Now, what if I don't measure it appropriately? So this beautiful study by Professor Salmon, it is a simulation study. So what does it tell us? That if you don't measure accurately, nothing much will happen in a low risk patient or extreme high risk patient. But patient who are at borderline, let's say who have an NT of 2.5, 2.7, or who have a maternal age of 32 to 35, in 25% of these patients, you will screw up the screening, because even a 5 mm change in the CRL can make these patients as a high risk or a low risk, which is false. So that is why an accurate CRL is most important. So once we are done with CRL, we do the NT. Now everyone, all of you all know how an NT is done, but just because of the sake of presentation, we'll revise how an NT is done. So these are the anatomical structures what we are supposed to look when we are taking an NT scan or an NT profile view. The diencephalon, the midbrain, the pons, brainstem, cisterna magna, and the nuchal translucency. And to get a good NT image, the magnification should be good. It should be in the true mid-sag, neutral position, and the calipers should be well placed, and you have to see the thin lucency there. Once the criteria are satisfied, then you can consider the NT for further screening. And once you learn how to take a good NT, you can get yourself certified from the FMF also. So only when you have a good NT and a good CRL, you can send the sample for double marker. Otherwise, the double marker report will return as a false positive or a false negative. In such cases, it's better not to do any screening. So how do you know that it's a good NT? There are only two ways. Either, as ma'am said, Bela ma'am, that you examine all the images of NT and which you get from your imaging specialist, or choose an imaging specialist who is FMF certified. Simple. As they are more likely to give you better images than people who are not certified. So having said, we must also know the detection rate by the methods of screening. So if you use only the maternal age, the detection rate is only 30%. And if you combine maternal age with NT, it is 80%. Maternal age with biochemical markers, as all of you all know, beta HCG and PAPA double marker, the maternal the detection rate increases to 60 to 70%. If you include all the FMF criteria, the maternal age, NT plus beta HCG, then it goes to 95%. And all the FMF criteria, the NB, DV, NTR, then it can go up to the 96%. So what is the first trimester combined screening? It is the NT scan, and the NT scan has to be done between the 45 to 84 mm. Any measurement you see beyond this or below 45 or above 84, it is of no use for a combined screening. Double marker, you know, dual marker, what it has. and the detection rate goes up to 95% when you combine all this. So when we get a result, what are we supposed to do? We are supposed to get a risk assessment. So when it is a high risk, advise invasive testing. When it is intermediate risk, you opt for NIPT and invasive testing. And when it is a low risk, you reassure, but you explain the residual risk. Low risk does not mean zero risk. It means that the likelihood of a mother having a child with Down syndrome is much lesser than a general population or people who did not even undergo first trimester screening. But that does not mean that she will absolutely not have a child of Down syndrome. So we should make them understand that this is a screening what we are doing. High risk, we do further definitive testing. Low risk means there are less chances only. So how do we understand this whole scenario of combined screening? I'll take you through some of the cases and understand how we are going with first trimester screening. So this is the case 1, 27-year-old G2P1L1, and the NT is 1.4 mm. What should I do? A double marker, a triple marker, a quadruple marker? Anyone, please? Anyone? What should I do? What investigation for a combined screening?
Double marker.
Double.
Okay. Agree. A double marker. But obvious because we are doing an NT of 1.4 mm. But have I shown you the image? Do you see any image in the report? So in most of the NT scan that we see in our OPD, there is no NT image, which means it does not qualify for a good NT scan. Then you should not accept an NT scan because you cannot, just because of the measurement, you cannot give for a combined screening. If you want to accept an NT scan, there should be an NT image, a CRL image, and it has to be a satisfactory one. So before sending a double marker, you should see an image because imaging it's a part of a curriculum and you must know NT and CRL are very basic. If there is no image, that means the NT is not done. At least this is what I have been trained for. And if you listen to Dr. Suresh, he's a pioneer in fetal medicine in India. He always says that you should have an NT image on your table under your glass. So every time you get an NT report, you can use it as a reference image. And if it does not match the standard, we do not do screening because more often it's going to give you a stupid screening. So this patient, we can take it as a scenario that you send back to me. That's all. Where is the image? I don't find any image. So I give you this image. Do you see an NT image there? Median profile and a good CRL. Do you all agree with a good NT, good CRL?
Yes.
Because a good CRL will tell you the gestational age. So a good CRL, okay, and a good NT. Now we send this patient for double marker. Now, so this is the report of a double mark. What is the final risk here? 1 in 798. Correct? So combined risk for T21, 18 and T13 is low risk. But do you look, the beta HCG is 3.99 mom and the PAPA is 0.7 mom. And you see the biochemical risk alone is increased. And this is just a screening. So based on double marker detection rate is only 60 to 65%. Are we going to act upon the double marker result alone? Considering the patient is only high risk for biochemistry. So we do not act on biochemistry alone. We always act on combined screening, and the combined screening is low. As I've shown you, the detection rate of combined screening goes up to 95%. So just because the beta HCG is high and we are not going to act, because NT we have approved, the CRL images also you have approved, and we have sent the sample to a good lab which works on software like PerkinElmer, which are FMF certified. So all are FMF stakeholders here. So we do not have to worry. We have to rely on combined screening, not on biochemical. I hope you got my message in this. Now next case. NT 2.7. Is it a good NT? Yes.
Yeah.
Now, NT, we have 2.7. What should we do? Double marker, triple marker, quadruple marker? Anyone?
What is the gestational age?
The CRL is around 64 and it is around 13 weeks, ma'am.
Dual marker.
Okay. Now, before sending it for a double marker, you should know what centile this NT stands for. So, this beautiful paper by Pratima ma'am and Anita ma'am on Indian population with around 14,000 subjects tells us the normogram for NT. And in this normogram, 2.7 is between the 95th centile and the 99th centile. So we can go by double marker, and we did the double marker. The result was low risk, right? So now she's low risk. I have done the NT. You have approved it. We have sent it to a good lab and everything is fine. So I've reassured her and sent her. But somebody in a family, some known doctor relative, told her that your NT is written as more than 95th centile. You should do further testing. She Googled up and she came back to me that, sir, I want to do further testing because there is a NT is this and there is chances of being downs and other things. So I told her, ma'am, we have looked at the anatomy, we have sent your sample and we have got a combined risk, which is low risk. You need not worry. Please continue the pregnancy. We'll see you at an early anomaly scan. She came back again to me. This happened twice, thrice. So the third time she came, I counseled her for both NIPT and amnio. She agreed for an amnio and we did her amnio and this was the result. Negative for any aneuploidy. Now for a low risk patient, for a borderline NT, I have done an amnio. Is it fair? Is it fine?
No.
Or I have done it for money? At least some of you guys know me here. Will you think I'll do it for money? So
No,
why I have done it?
Patient was insisting.
Yes. So why I have done it? Because I know, first thing, patient was insisting. Second thing, I know Downs cannot be diagnosed by sonography or any form of blood test. And the patient was so keen knowing about the chromosome of her own fetus. I cannot refuse every single time she comes to me. It is their wish to get an investigation despite knowing all the risk. Correct? What if every time I'm reassuring her and God forbid it's a bad day for me and for her, and if this child turns out to be down, because low risk does not mean zero risk, she'll kill me. She'll say that I came to Kulbhushan sir thrice and he did not test my fetus. It is his responsibility, right? So why did I do it? Is there a scientific evidence to support my decision? Yes. This ACOG Bulletin 2020, which says that all the screening and diagnostic tests should be discussed with the patient and it's couple choice to accept or refuse. The couple wanted to do an investigation and you should do one, right? Agreed? I hope you got my message there. Now, I'll take you to the next case. Third case, NT 3.4 for a CRL of 74. Have I measured the NT correctly or there is some problem? Let's see in this section. This is the axial section, ma'am. You can see there is edema there. Also, the TR. This is the 4-chamber view, which is showing the tricuspid regurgitation. So what do I do? NT 3.4. I have TR also there. Should I do a double marker, triple marker, quadruple marker? Anyone?
Invasive testing.
Okay. So good. If NT is more than 99, you straight away go for invasive. Now 3.4, according to the centile, is but obvious going to go above 99 centile. Okay. So whenever an NT more than 99 centile or NT more than 3 mm, there is minimal benefit. And when NT more than 4 mm, there is no benefit. We straight away go for invasive. So I offered invasive testing for this patient, but patient did not approve and did not follow back. So why I said so? Because of this landmark paper by Professor Kipros, and it is easily available on FMF website. You see, if NT is more than 95th percentile but less than 99 percentile, the chromosomal defects have slightly increased. But when NT goes beyond 99, the chromosomal effect grow exponentially. Also, the major abnormalities increases, and that is why more than 99% always go for invasive. Agreed? Now, I'll take you to my next case. You see this? There's bilateral renal pelvic dilatation. Structural abnormalities. This is a first trimester scan. So, if there is a structural abnormality, we do not do screening. No combined screening, no NIPT, we go for invasive. If the patient wants to continue, straight away invasive, because structural abnormalities are associated with copy number of variations, and copy number of variations are more common than downs. So we do not screen for downs, we straight away go for invasive, mostly microarray. Now I'll take you through some of the NIPT cases, as we are done with the first trimester combined screening and its implication. Now, because everyone offers NIPT and the way it is marketed, that's such a fancy test, many people want to do it, but whatever you talk, it still comes under a screening test. Maybe a good screening test for T21 only at present, but still a screening test. So let's understand some NIPT conundrum which we face. Now this patient came on NIPT high risk for T21. They came for in counseling. What should we do? I said it is positive on NIPT, and probably same answer might come on invasive. They agreed. We did invasive. It was positive for T21. Good, because NIPT has a good sensitivity for T21. We got one in invasive also. Next case. This patient was sent from a gynecologist directly for NIPT, and it came out to be positive for sex chromosomal abnormalities. The patient came to me. They again Googled up everything, and they came like sex chromosome, so many problems, this, that. I said, if you want to confirm whatever has come on NIPT, we have to do invasive. So I counseled the patient well. Patient was more keen on terminating. I said, we have to do a test and confirm. This is not a right answer yet. So the patient agreed. We did her invasive, and look at the result. It was negative for any abnormality, even sex chromosome. Everything was normal. Because NIPT does not have a good performance for sex chromosome. Next case. This patient was positive for T18. Same scenario. We did invasive, and it was normal on invasive. Next case. So this patient was high risk on a double marker. Patient came to me. I counseled the patient, give both the options, and patient agreed for invasive. Look what result we have. The mosaic type of trisomy 21. Now, only 15% of cells will show the copy number of variation. Extra copy. Other 85% will remain normal. Now, if we go back, I had given option of NIPT also to the patient. What if the patient would have agreed NIPT and done NIPT? It would come low risk and would have continued the pregnancy. The fetus would have been born, and sometime in life they would have shown some features. They would have come back to me that, why didn't you tell me there was a definitive testing? I would have done it. So we have to be very careful and understand the sensitivity of test which we are offering. Now, this is my last case. You see the 3D face? Looks like a typical syndromic slanting upward eyelid, Mongolian face. Let's have a look at 2Ds, absent nasal bone, a double bubble, AVSD. In this section, I'm trying to show you the hard AVSD. So these are very classical for Downs. So all the features point towards down. So shall we straight away label it as Down? No. Why? Because Down syndrome is not a sonographic diagnosis. No matter how many features we have on USG, the only way to diagnose Downs is by karyotype. So we offered karyotype to this couple, but couple did not agree because of the advanced gestation. So are you guys aware of what are the types of Downs? I've shown you the commonest one, trisomy 21, which are there 95%. Translocation one, I'll show you one, and mosaic time one, which we have one case. So in translocation, here you can see there is a translocation between the 14 and 21. So this is a Robertson type of translocation. So what are the don'ts of screening? No screening if NT is more than 3.5 mm or more than 99 centi. No biochemical screening for triplets or more. No screening if CRL and NT is not right. No double marker alone in the first trimester. Use combined first trimester screening. No screening within the 1 week of injection of beta HCG. No screening if donor DOB is unknown in ART pregnancies. No screening if multiple markers are present. And no screening if anomaly is detected. I hope you got my point there. Now, this is an eye-opener case for me. This is not my case, my story. This is case given to me by one of my guru, Dr. Varun Ashok Thakur. He's a director at Sri Molly Diagnostic, Pune. This incident happened with him. A couple came to him at around 32 to 34 weeks, asking directly for a report of abnormal report where they wanted to terminate the pregnancy. He said, I don't do such practices. In your referral sheet, there's written a growth scan. I'll do that and I'll share the findings. He did the scan. It was an FGR, and the mother was under preeclampsia screening. So he gave the report and informed the obstetrician that, ma'am, this is a scenario with the couple. Please take care. He said, okay. The baby was delivered at 35 weeks, and it was a male child. As you can see here, the whole family left the fetus and went. Imagine a male child being left in India. I don't think so anyone will leave. So what was the problem there? When they had been diagnosed at 26 weeks for FGR, someone counseled them that the baby is going to be weak, the baby is going to be mentally abnormal and Downs and stuff. And that was set in the mind that the baby is abnormal. So just because of someone's advice or someone's one word led this fetus in such a state. So the gynecologist called back Dr. Varun and said, so this is a scenario. So Dr. Varun said, let's investigate, ma'am, and prove it that it's not a Downs baby. I think everything will be fine. They investigated this fetus and everything was normal. So we should be very cautious with the words what we use. We should not say, like, just be callous in our approach. We don't know what the patient will take from it. So my take-home messages are, good dating with CRL is mandatory. Do not approve a report without images. Do not screen when there are structural abnormalities. Do not repeat markers. NIPT is not a definitive test. Do not terminate on the basis of screening test. Consider definitive test when indicated. Choose your imaging partner carefully. And I would like to thank my guru, Dr. Adi sir, Adi Narayan Makam sir, Dr. Varun sir, Dr. Purvi Agarwal. Every step I take every day, their blessings and their guidance. Thank you so much. And it's a great honor for me today to share this platform with all the dignitaries. Thank you, Monica ma'am. I'm a small town youngster, and thank you for giving me this opportunity.
You know, you are not a small town youngster, Kulbhushan. You are, you are destined for the stars.
Thank you, ma'am. Thank you.
After many, many months, I've listened to such a great lecture on fetal medicine, and your take-home points and your do's and don'ts are just mind-boggling. I have taken screenshots
madam.
of all your slides. So over to chairpersons for your comments after this great talk.
Very
Thank you
true,
so much,
madam.
Monica, ma'am. Once again, absolutely agree with you, Dr. Kulbhushan. It was a fantastic talk. And to say the least, I'm delighted to be a part of this prestigious webinar and listening to Prashant Acharya sir, Bela ma'am, followed by Dr. Kulbhushan. And I would specially like to congratulate you for three things. One, कि एक स्क्रीनिंग टेस्ट के बाद फिर से एक सेकंड स्क्रीनिंग टेस्ट करवाना जो बहुत पॉपुलर फैशन हो गया है
Yes,
does
ma'am.
not make sense at all. सेकेंड जो अपने को शुरू से मेडिसिन में पढ़ाया जाता था कि टू डू तो सब बताते हैं बट व्हेन नॉट टू डू इज एक्सट्रीमली इम्पोर्टेंट which
Yes,
you
ma'am.
very strongly highlighted and emphasized, and that lovely case collection that you had, and you used it so beautifully to demonstrate all your points. So congratulations, you clearly not only have a good subject knowledge, but you're a good orator as well. So thank you so much. Thank you, Monica ma'am.
Thank you. Comments from you, Dr. Kalpana?
Yes, thank you, Dr. Kulbhushan, for throwing light on this very important topic on first trimester scan. During my PG time, means 16, 17 years back, not much stress was given to first trimester scans. We were taught about the importance of second trimester anomaly scans. Patients also refrain from repeated scans, but now the scenario is totally changed. First trimester scan is now equally important. A good first trimester scan will tell you chorionicity, gestational age, NT, NB, neural tube defects. Dr. Kulbhushan has very well explained all the queries that were in my mind from a long. Especially, I like the slide of no screening, when to do no screening. Thank you so much, Dr. Kulbhushan.
Ma'am, in fact, I would just like to share briefly one of my cousins in Gwalior. They were advised quadruple test at sometime around 17-18 weeks. तो एक तो मतलब उस समय पे क्यों advise किया? And then obviously it came somewhere in intermediate या high risk. And then they were advised termination. So then immediately I told them that, and till that time they had not kept me in the loop about what is happening with the pregnancy. So then finally I asked them to contact one of my friends, and then thereafter now they have a very healthy baby in hand. So again, Kulbhushan sir, a very important point that sirf screening test ke basis pe a pregnancy should not be terminated. And that last tagline that you had, every baby should be given a fair chance.
Thank you.
Yes, that's very true. And there are also some misconceptions in people's mind about NIPT. NIPT is not the holy grail. NIPT is very, very sensitive for downs, no doubt. But it has to be taken with a pinch of salt as far as trisomy is concerned, trisomy 18, 13, and so many other sex chromosome disorders, which NIPT is not very sensitive for. So advising NIPT left and right is definitely, misguiding the patient and probably misguiding yourself. So you should know when to do combined screening. You should know when to advise amnio. You should know when to do the combined test and how to interpret it. Dr. Kulbhushan, you did not talk about CVS. When do you do chorion villus sampling, and do you do it in your practice? How often, and what is the utility?
I'm against it.
Okay, I realized it because you were not talking about it.
If you listen to there are a lot of webinars by Suresh sir, so there are a lot of maternal cell contamination and other things, and it is like you putting a pregnancy at a risk also and pain also for a patient. I in Harda, I've done more than 100 amnios, and I've just done one CVS.
Right.
Because the patient was already suffering from previous thalassemia, major thalassemia, first fetus. For that I had done, but I always push the patient. It's okay if till 16 weeks if you wait. There's no harm in waiting. To have what if everything is normal and because of one CVS everything goes haywire?
Yeah. So I think we will need a session 2 from you, Dr. Kulbhushan, very soon, so that we can clear our doubts and definitely continue, because this is something, this subject fascinates me. And I must give regards to Dr. Asha Jain from Raipur.
Yeah, I
who
would
has,
like to thank Asha ma'am who
yes,
gave my
actually,
reference.
yes.
Without her, I would have been not there in this platform.
Dr. Asha Jain was supposed to be the third speaker for today because Madam is also a fetal medicine specialist, and we have all known how passionately she has fought for the elections and she has won the elections.
Yes,
So,
yes.
Dr. Kulbhushan, you are the gem or the Kohinoor who has been handed to us by Asha Jain ma'am, and I will personally thank her. Thank you so much.
Thank you.
And that brings us to the end of this webinar in association with AMPOX, in association with Agra OBGY Society, Faizabad OBGY Society, and Mao OBGY Society. We collaborated with dynamic speakers from all over India in the presence of esteemed chairpersons, our own AMPOX President and Dean GMC Bhopal Kavita ma'am, our esteemed special guest Dr. Yashodhara Gaur, our guests of honor Dr. B. Kalpana ma'am, and Dr. Who was the second guest of honor? I've forgotten. Savita Tyagi. Dr. Tyagi was
Savita Tyagi.
guest of honor. So we are so honored to have all of them, all the dignitaries, and the three talks, which were totally in sync with each other. And I'm sure with these talks, we will be, more motivated to study fetal medicine, to understand fetal medicine, do a lot of good to our patients, and to take AMPOX forward. So in the end, I thank all my team. I thank my coordinators, Neetu, Purva, and Nandini. I thank Dr. Vishal, who is always there, rock solid support for our team. And I thank Inta Studio. This program was running live on YouTube, and we have got a number of questions and comments on YouTube also. I urge all of you to like and subscribe our YouTube channel so that you will keep getting updates. And we are going to give you special and brilliant sessions. We'll try to do it twice a month. Thank you so much and have a very good night.
Thank you, ma'am.
Thank you. Thank you so much.
Thank you, ma'am.
Bye. Bye, everyone, and good night. Bye.
Good night.
Supportive, you can stop the